Hello, good morning, everybody. So we are really happy to have here Dr. Ian Kevin. Ian is an MRI clinical scientist, medical physicist, and certified MRI safety expert. He has a bachelor in pure and applied physics, as well as a master's degree in biological nuclear magnetic resonance. He started his career in Nine Wells Hospital, Dundee NHS state site after completing his PhD at the Sir Peter Mansfield MR Center at the University of Nottingham, using the UK first 7 Tesla MRI scanner. Ian has skills and experience of working at 3 Tesla in areas such as magnetic resonance, functional magnetic resonance, MRI, high-intense focus ultrasound, clinical adult and pediatric brain spectroscopy, as well as supporting MRI clinical research for cardiology, neurosurgery, ophthalmology, psychology, psychiatry, and radiology. The development of pediatric MRI video entertainment system for young patients who would otherwise require general anesthesia during MRI is a project he is most proud of. Ian now is working at the Royal Infirmary Edinburgh, Scotland, where he is the principal medical physicist in magnetic resonance imaging. So thank you very much for being with us, Ian. So is now for you to share your knowledge. Thank you.
Okay, thank you, Sylvia, and buenos dias, everybody. I hope you find this interesting, and I will kick off straight away now with the talk. Okay, just a brief outline. MRI is a subspecialism within the medical physics field. However, I work in a department that also includes the use of ionizing radiation, non-ionizing radiation, which includes medical physics. So the overview of the talk will give an indication as to what type of work goes on in the department, in the hospital that I work in, and I'll give you a little bit more detailed information on the role that I carry out as an MRI physicist within the health service in Edinburgh. So again, MRI is a subspecialism, but we also use ionizing radiations, and the other departments that I work alongside include radiation protection, which covers the protection of patients and staff from ionizing radiation, so ensuring doses that both staff and patients receive are below certain thresholds depending on the types of examinations and procedures that they're carrying out. And radiotherapy, which is another department for treating oncology patients, and they have received relatively large doses of radiation, ionizing radiation, and how that's delivered will determine how successful their treatment planning is likely to be. And as well as that, nuclear medicine is a subspeciality where radioactive isotopes and pharmaceuticals are used for identifying pathology within the body. And the area of non-ionizing radiation, including the use of visible light, ultraviolet, ultrasound, and as well as magnetic resonance imaging. So this is a general overview of the structure of the department that I work in. So radiation physicist, although that's not my area, I'll just give you an overview of what types of activities and their role is. And ideally, the objective is to obtain the best results from diagnostic imaging with the lowest possible dose of ionizing radiation. There's this risk-benefit analysis and also achieving the best possible outcome with the minimum damage as a result of the use of ionizing radiation. And this also includes staff monitoring staff exposures while they're delivering the imaging and the treatments for patients. So the typical jobs or tasks that they carry out include they check and they calibrate equipment to ensure that the correct quantities of radiation are as specified for the types of treatments. So this could be an X-ray system, a CT scanner system, mammography units, and they also ensure the compliance and monitor the radiation levels according to radiation ionization regulations. And there. A radiotherapy physicist, so their involvement are involved with the treatment of cancer using ionizing radiation, and there's different types of deliveries. So there is the short-range brachytherapy, which involves the use of seeds or wires or implanted radioactive materials such as cesium and iridium that are actually very close to the cancerous tissue, are involved in destroying these cancerous cells so they can no longer replicate. However, the most common type of radiotherapy treatment is external beam. This is where beams of radiation, can be X-rays, electrons, or protons, are aimed at the tumor from outside the body, and they are combined on a central target. You can see here the different radiation doses that's received in and around a tumor from this CT scan. And the idea being that if you deliver multiple X-ray beams from different directions, you reduce the damage to healthy tissue through which the radiation is transmitted through. So the physicist involved would be involved in treatment planning and beam shape to try and reduce the dose to surrounding tissues. And they're attempting to accurately model the size and shape of the tumor, as well as minimize the dose to the surrounding healthy tissues. Nuclear medicine, again, involves the use of radioactive substances for diagnosis and monitoring cancer patients. So the principle being that certain radioactive materials are inserted into the body and as a radiopharmaceutical and collect at a specific site. You can see here an example where we have a PET CT scan. You can see some primary tumors here highlighted in the very dark, dense color. So this is a type of scan that will help identify actively progressing tumors and allow appropriate planning for follow-up treatment and so forth. So the role of the physicist is ensuring that the quality control of the equipment that's used is as per it should be. They're involved in the calculation of the radioactive activity needed to treat the tumor, and they may also be involved in the administration of some of the radiopharmaceuticals. And they will be involved in testing and commissioning some of the radioactive equipment, of the equipment that's actually used in treating the patients. Onto there. So non-ionizing radiation, that could involve the use of things like ultraviolet radiation. So for treating psoriasis or skin conditions. So it's a dermatology department that works with the medical physics department to support that. And radiation of different wavelengths can be used to treat and kill bacteria and viruses in various scenarios. The other ones, for example, neonatal jaundice, when neonates are born, sometimes they have problems breaking down chemicals in the body called bilirubin. And it's been found that blue light phototherapy can be used to help the body to break down these chemicals. And further along, there's the microwaves, radio waves, static magnetic fields that are involved with, well, we'll discuss a little bit more about that in terms of MRI, and as well as the ultrasound for various scanning procedures on there. However, for the remainder of this talk, I will go into discuss my area of expertise, which is MRI, which is magnetic resonance imaging. So my journey to where I am now, as Dr. Sylvia Hidalgo had said, I have been involved in MRI for in excess of 15 years. But in order to start off this journey, I undertook a 3-year degree in pure and applied physics, and then carried on with a little bit of research into biological nuclear magnetic resonance, a 1-year course. Undertook a PhD, which lasted just 5.5, 6 years. And then I enrolled on a clinical scientist medical physics training scheme, which lasted 3 years. And that involved me specializing in MRI as well as gaining some basic knowledge of the physics that is actually carried out in the different specialisms within the medical physics. So at the end of the procedure or the process, I now become a state registered clinical scientist. I submit a portfolio of work that I have carried out over the 3 years, and I do on-the-job training, and as well as that, I'm interviewed as part of an examination to ensure that I am safe to work with patients thereafter. However, subsequently, I've considered it quite important to progress and undertake further qualifications. So one such qualification is a US-based organization, American Board for MR Safety. So I undertook an examination, and I'm now certified as an MR safety expert. So it's just ensuring that I keep my knowledge up to date with the current advances in the technology and so forth. So the sort of things that I might be involved with, or I have been involved with over my career, have involved the procurement, which is the purchase of equipment, the design of MRI facilities, the commissioning and acceptance testing of MRI scanners. So that's every 8 to 10 years we will replace MRI scanning equipment or introduce new MRI scanning equipment. So it's not happening on a day-to-day basis, but it usually takes 2 to 3 years to lead up to the purchase of equipment. So you're involved in commissioning and choosing equipment that's appropriate for your specific department. For example, if it was a neuroradiology department, they'd be maybe looking for certain specific pieces of software that work within a scanner. Or if it was a cardiac clinic scanning facility, they'd be looking at MRI cardiac sequences. However, on a more regular basis, the day-to-day activity would involve various safety aspects of it. So it's safety, education, and training for all staff. So the health organization that I work in has 28,000 staff, and we are required by law to provide all of them with some level of training that involves MRI safety. However, we mainly focus on a much smaller group of staff, the MRI radiology staff, to ensure that they are fully understanding of the legislation and also the safety aspects of MRI. So things that I would be involved with on a day-to-day basis might be involving testing equipment, scanning equipment, assessing patient implants for safety. Is it safe to scan these patients on a particular field strength, 1.5 or 3 Tesla? And in the rare occasion when things do go wrong, we have incidents, and we're required by law to report these and investigate these and ensure that we put procedures into place so that they don't happen again. More clinically focused work, it could be things like pre-surgical fMRI, which I'll talk a little bit more about in this presentation. It could involve the development of breast MRI protocols to ensure that the best quality imaging is achieved in particular scanning sequences. It could involve quantification of cardiac MRI scans, measurement of liver iron concentrations using MRI. It could involve brain or prostate spectroscopy, or it could involve some image sequence optimization. And every year, we normally provide training MRI physics lectures to trainee radiologists. So they are basic medical students who finished their basic medical degree and wish to specialize in MRI. And as well as their training, we provide training to other clinical scientists and other medical physicists. To radiographic staff, we have an ongoing training program to help them develop their understanding of the principles of physics and help them optimize sequences themselves. And as well as that, the non-MRI staff, the clinical referrers who refer patients for MRI, the nursing staff, anaesthetists, and neurosurgical staff as well. So it's quite a broad range of activities we undertake on a daily basis, but every day is very different. So it's quite an interesting and enjoyable job that I have. So I'll move on. And a little bit of history about MRI. MRI hasn't really been around for all that long. It's less than the age of your department now, 50 years old. but it was around about the late 1970s that the first human subject was scanned in MRI. And the first commercially available clinical MRI systems came on the market in the early 1980s. And now I think there's somewhere in the region of between more than 20,000 MRI scanners worldwide. So the modality has expanded over the last or in the last 40 odd years. So there has been quite a progress in that area. And during that time, over the last 40 years, there's been progress in a number of areas in terms of hardware and software. So the first MRI scanners were actually around about 0.1 Tesla or 100 millitesla. But typically nowadays we have field strengths of 1.5 Tesla or 3 Tesla in the clinic. 7 Tesla and 11.7 Tesla are typically research systems with a focus on often neuro, not solely neuro, but primarily neuro, because you go up increase in magnetic field strength, it doesn't always mean that the stronger magnetic field strength will be useful for imaging all parts of the body. So, but now more recently, we have new MRI vendors selling much smaller magnetic field strength systems, 0.55 Tesla. And there's even now a portable MRI system that can be wheeled around a department. So these are things that you may suspect seem quite surprising. It's not necessarily the progress in the field strength that drives the technology. It's often now the image quality of the lower field systems, and these portable systems can answer certain clinical questions. For example, if a patient had had a stroke or a hemorrhage, often the image quality is now sufficiently good at these low field strengths and provide a much quicker response to a clinical question and ensure that the appropriate patient management is carried out in a much more timely manner. As well as that, we now have what they call helium-free MRI scanners. Typically, MRI scanners had between 1,000 liters and 1,500 liters of liquid helium. However, in this hospital that I work in, we now have one MRI scanner. It's 1.5 Tesla, and it only has 7 liters. So there are safety implications associated with that, as well as cost implications. Helium is very, very expensive, and in the unusual event when it quenches, it can cost somewhere in the region of £20,000 to have the helium replaced and have the system operational again. So £20,000, I think that's somewhere in the region of $50,000 or thereabouts to have the system up and running again. So the less helium it has, then there are safety implications are you don't necessarily need a quench pipe, which is part of a safety system. So it can tend to be a little bit cheaper. And I mentioned there the progresses in image quality. So there are now artificial intelligence and advanced image processing applications that are provided by all MRI vendors. And they are certainly improving, in some cases, image quality for imaging lower field systems as well as the high field systems. So we'll talk about MRI in itself, but it's actually over the last 10 to 15 years advanced in such a way that we have MRI combining with other modalities and developing in other areas. So intraoperative MRI, patients can now undergo neurosurgery and have an MRI scan midway through the procedure to identify whether all the tumor has been removed. And we had one of these facilities installed in our hospital in the last 4 or 5 years. And there's MRI in high intensity focused ultrasound and MR guided laser ablation, and as well as that PET MR and MR Linacs, where we combine the use of ionizing radiations with the diagnostic image quality of MRI and the MR guided linear accelerators to just ensuring that these technologies are now combining to ensure the better outcomes for patients in certain oncology situations. So for those less familiar with MRI, there are typically 3 magnetic fields associated with them. So I say a static magnetic field. So typically you'd find in the UK, you will have up to 7 Tesla, but normal hospital systems are 1.5 or 3 Tesla. They also have a gradient magnetic field, and this is the noisy part of the MRI scanning sequence. And these audio frequencies are in the kilohertz range and often are of high amplitude. So that's why staff and patients require hearing protection. And there is also radio frequency waves associated with MR scanning in the megahertz range. So one of the safety considerations is radio waves can, in certain circumstances, cause thermal injury or burns to patients on the surface, typically. But we'll discuss that in a little bit more detail as we move on. So in terms of the typical role that I'll provide on a given day, it would often be involved in MRI education and training. So on this slide, I've identified 2 images here of the similar slices within the brain. And we can see here there's different contrasts between what we call an axial T2 weighted brain image and an axial T1 weighted brain image. So I would typically be involved in explaining and advising radiographic staff as to why these images are different. What are the physical principles as to why these images are different? So we would give them a basic course in how MRI works, and just explain to them why the physical properties of the tissue that result in these images being different, and the selection of the MRI sequence parameters that ensure that you can develop different contrasts. In some instances, we can see here there's a bright signal from the T2 weighted image. It shows you the cerebrospinal fluid. And in some imaging sequences, that can obscure certain pathologies. So it may be preferential to have a T1 weighted image that shows no signal from the CSF. So certain types of imaging sequences form part of a protocol that a radiologist would require to identify certain pathologies. So these images on the right here, you can see a large signal void around this pediatric brain image. So this was about a couple of years ago. We had a pediatric patient come for an MRI scan, and it was noted afterwards that the patient was obviously, there was something not quite right here. And it was identified that the pediatric patient had actually put a small battery inside their nose. So even very, very small objects can have a large impact on the image quality. So there was no further harm done to the patient as a result, but this can be actually very frightening for a radiographer or our MR tech to see on a scan, because this may suggest that there is potential injury to a patient. But in this case, this battery was actually removed following this scan being carried out, and the patient underwent a subsequent MRI examination without concern. The other thing is the safety of ensuring that when patients do undergo under MRI scanning, they do not form loops. Physics says that formation of loops, or the shapes of certain conductors, body tissues do conduct, can cause burdens to patients. So we're always advising them to ensure that they use patient padding and put them in the appropriate places. I have had in the last 10 years, there have been 2 instances where patients have suffered thermal burns, but we've now put procedures into place to ensure that that doesn't happen again. The other aspect is this image here in the lower right is just showing the kind of basic principles of the components that would form up to make an image. So this would be forming part of their teaching materials that we would go into some of the basic physics. So probably one of the key things that I've learned when you teach people or involved in educating people that are not necessarily familiar with physics is always present things with as few equations as possible and present them in the form of pictures, because that certainly helps them understand something, and they would much more readily understand and ask questions following things like that. So what I would like to do, I would like to go into a little bit more detail about the training and education, because in 2021 we had a very serious incident in our hospital. It was only opened up in the beginning of 2021, but 4 months later we had an incident here. So in the bottom right-hand corner of the screen, this is an MR unsafe bed was taken into the MRI scanner while a pediatric patient was on board, and the patient was unharmed. However, the bed was stuck to the scanner, and it was also subsequently found that there was an MR unsafe oxygen cylinder underneath the bottom of this bed. So the patient had been transferred from another department within the hospital, and the transfer had not been made onto a suitable MR conditional trolley. So this could have been a very serious incident. And the other thing that was attached to the patient was a pulse oximeter, which was MR unsafe also. So we were very, very fortunate. The only injury that happened as a result of this was to the anaesthetist, who had his finger trapped against the scanner when the bed was pulled into the scanner room. However, the patient was then under anaesthesia at the time and was transferred to another MR scanner elsewhere. So it just shows you, in certain circumstances where new members of staff were who had not had updated safety training had essentially forgotten what was required prior to entering into the MRI scanner room. And one of the primary issues is patient burns are the most frequently reported incident, certainly in the UK, and this is due to electric fields generated inside the body. So we are always very vigilant that any pieces of equipment that are attached to patient are checked for MR safety. So we have very few incidents, but there are certain situations that arise where we would always ensure that patients have any implants or any objects attached to their person, that they're removed in advance. We also ensure that there's lots of safety signage in place, and they're given training on what all of these sensors are and what they should do, what staff should do in an emergency circumstances. A typical procedure you would see for an MR physicist would be involvement in the development of sequence protocol. So this dynamic breast scan here, you can see there's a large spherical tumor here and the vasculature associated with this tumor, and it's ensuring that the clinicians can obtain the best quality images. So this is what we would call a T1 weighted flash dynamic image. So the images are taken over a period of 8.5 minutes. And what we are always trying to do is to optimize the highest possible spatial resolution and give the best image quality to depict the pathology that's on the screen. So I'll run through some of the things that we would be involved in doing here. So we've got this resolution, the slice thickness, and also the voxel size in plane. Fat saturation. Certain tissues within the body can be very, very fatty, and these fat with the tissues can obscure pathology. So this is a type of fat suppressed dynamic scan that helps identify tumor pathologies very, very easily. And there are issues, acceleration factors. So I'll discuss a little bit more about parallel imaging. So this is a method of accelerating scans so that they take much less time. And the other parameters are hertz, so the frequency, to ensure that there's much less artifact, and in an image we make sure that the frequencies of the pixel bandwidth is within a correct range to ensure adequate image quality. In this case, we would acquire 160 slices, axial slices, and every 51 seconds, and this would be repeated to 10 times. So it's carried out during the injection of a contrast, and what you can see in the images here is the uptake of that contrast over that 8.5 minute period. So optimizing to ensure the best image quality is one of the roles that the MR physicist would carry out. Another case study here. This was a patient that I was involved with some months ago. So, as I said, MRI was developed as a clinical tool that was only introduced in the 1980s. However, we often have many patients that come for MRI scans. And in this case, this patient underwent brain surgery as a child in the 1960s. And she had four aneurysm clips here, as we can see on this lateral X-ray. However, when we try to review the records or obtain the details of these clips, it was very near impossible. We managed to track down that the patient was scanned or had the treatment in another hospital in the UK. We managed to track down our notes from the 1960s. However, but there was no details that would help us identify the make and model of the aneurysm clip. And here was the typical CT scan of what the artifact looks like on the aneurysm, what it looks like on a CT scan. So the primary concern with going ahead and scanning a patient with clips of unknown make and model is that some back in the 1960s and 70s and 80s were actually made of magnetic material. And there have been fatalities associated with the movement of clips when exposed to MRI magnetic fields. So unfortunately for this patient that was involved with, my advice to the radiologist and the referring clinician was it's very risky to try and proceed with the MRI scan of the head, definitely. And it would be advisable to proceed with a CT scan or other modality to try and answer the clinical question that was being posed. Here's another example of the types of artifacts that might come across where a patient has had a capsule endoscopy. So they're maybe looking at the digestive system, the movement of a capsule that's ingested by the patient, and these should pass through the patients over a period of days to weeks. However, this was something that was apparent after some months. So in some cases, these capsules can become embedded and are no longer transiting through the digestive system. And this is what may be presented. So in many instances, there was no injury to the patient, but this type of artifact or signal void on the different orientations makes it very difficult for a radiologist to diagnose any pathology within the region here or any problem with the tissue here. So one of the things that we would often be asked is, why would this happen? Why does this object create such a large signal void? So the point being is being able to communicate to both the patient, the clinical referrer, and the radiographic staff or radiology staff as to why it appears like this. So knowing and understanding the properties of the material from which it's made. And the key issue here is it's to do with the magnetic susceptibility that the materials are made of this capsule endoscopy. So it's a very, very small capsule of only a few centimeters in diameter, but it certainly creates a very, very large signal void for the patient. And this was another case that I was involved with about 6 months ago. You see these very hyper-intense signals here. This was a shrapnel from a shotgun. And the question was it safe to proceed with the MRI scan of the torso? However, what my advice was, it really requires a risk-benefit evaluation. It was very likely these pieces of shrapnel were on the skin surface and were not close to any vital blood vessels or nerves. However, in the instance for this patient, it was deemed much more suitable to involve the CT scanning department rather than an MRI due to the potential risk to the patient of causing further injury. And as well as that, you'd often see maybe signal artifacts associated with the MRI scan in this instance. And another typical issue is patients with cochlear implants. They can create very, very large signal voids, these small devices located behind the ear. And again, this is often of very little value when it comes to diagnosing pathology in the brain. The size of the artifact can be quite a limiting factor. So often magnets are attached to the patient's head as part of the cochlear implant. And even when the cochlear implant is removed, there is still a smaller but significant artifact that would possibly prevent any diagnostic value being obtained from the image. And here's another one of a pediatric scoliosis patient. So these rods are helping to straighten the spinal column. However, you can see there that there's a large signal void associated on the MRI coronal and sagittal views. So often when patients are referred for scans, it often has to be taken into consideration the impact or the amount of evidence or the diagnosis that can be obtained from images where there is metal inside the body and close to the imaging field of view. And here was a second case here. You can see these 1, 2, 3 segments of what was called an ECMO cannula. And this patient was very unfortunate to require some life-saving treatment and had a cannula inserted into their femoral artery. However, after some time, the cannula was to be removed, and it couldn't be removed, and it was clipped. And unfortunately, this young patient was referred for an MRI scan, and we had to carry out a risk-benefit evaluation here. And essentially, we tested this fragment inside the magnetic field, and it was very, very ferromagnetic. So the potential risk was that this could move and potentially cause some severe bleeding. And the advice was to scan only if critical. So in some cases where implants are retained, there is obviously a much longer term issue with having these implants remaining inside the body. It was considered too risky to remove it, but it was also considered a potential poorer quality outcome for the patient with such an implant retained in the tissue. And I think, as I'd mentioned before, safety, one of the key aspects is where inappropriate monitoring equipment is used, thermal injury can be caused. You see this finger injury with an MR unsafe pulse oximeter. And this other one here was caused by, there was no specific piece of equipment attached, but it is actually the forming of a loop here. You can see the blister on the hand and actually on the side of the thigh. So essentially what's happening here is the radio waves that are transmitted by the MRI scanner are forming electric currents that can be formed in loops here that are causing large currents between these small areas of contact between the thumb and the skin, and they've caused a large blister and a burn to the tissue. So it's not always just thermal injury. There are issues associated with other types of objects. In this case, there was a patient in India who took in an MR unsafe oxygen cylinder and was trapped and crushed as a result of the ferromagnetic cylinder crushing his abdomen. And I think back in 2018, there was a patient in the US exposed to the static magnetic field, and they had a fatal rupture of the middle cerebral artery. So having clips and such like objects that are unsafe can certainly have quite serious outcomes for patients. So I mentioned thermal injury was one of the issues that we often had, we've had in the past. So we've had a couple of reports of patient burns. So what we've advised now is patients actually wear scrubs. So they wear trousers so there's no skin-to-skin contact between the thighs or the legs. And they also wear scrubs that have no pockets. So there's no risk of patients leaving objects inside their pockets in the past. So in the last 2.5 years, we have had no reports of patient burns or patient thermal injuries. So that's one of the things that the MR physics team have been involved in implementing, is just reducing and mitigating factors that may result in patient burns. So the other thing that we're providing a great deal of is MRI safety training, practical training and simulation. This would involve emergency evacuation of a mock patient from an MRI scanner, just so that the staff can do this safely. It would involve the emergency room technicians, the cardiac arrest teams that come into an MRI department. They would be involved in this sort of training. So that's ensuring that they are aware of the potential risks of the static magnetic field, and not to take equipment into the scanner room that are likely to make a scenario or a situation much more serious. So other factors other topics that we would involve with is the routine clinical support for identifying pieces of software or imaging sequences that would help answer clinical questions, such as the amount of fat in and around the liver, or iron deposition in the liver. So we would be involved in the identification of the software, evaluate the software, different softwares and the hardwares, and then just design tests to ensure that it's actually robust when it comes to being used in the clinic. So for certain patients, there will be a change in their treatment management if they can measure excess fat or iron in the liver, and how they would be treated. So we're often after to evaluate new bits of software or hardware that are provided by MRI vendors. The other one is that's occasionally requested is spectroscopy, primarily for the brain. So within the body, there is a large proportion of water, and there are also much smaller concentrations of metabolites. So it's ensuring that you can provide some clinical input into the selection of the appropriate spectroscopic sequences. So in this case, you have a very large water signal that would have to be suppressed. You apply RF pulses to suppress the water signal, and then you can determine the chemical metabolites that are present in the brain. And this image on the right here is showing you some of the chemicals, the location, the small voxel location, and the presence of the metabolites for evaluation. So some radiologists have specific training in interpretation of this type of information. Often we'd provide some basic level of training for them, and then advise the radiologists, if they're interested, to go and do some specialist courses to advise to understand that a little bit more. You can also apply the same thing to, as well as the brain, you could also apply the same spectroscopy to the prostate, and it's helping to plan that. We would help do the radiographic staff to plan this type of sequence. Often you need to apply suppression of fat from the surrounding tissue, otherwise that can interfere with voxels. And advise on the sorts of sequences that the options you would use for your spectroscopic sequences. We would advise and test the software, and also help analyze the data, ensure that the data is of the best possible quality for the patient. Other things as well, in certain situations, patients can't keep very still. So motion is often a problem, and you can see this image here on the left. There's a lot of artifact as a result of the patient unable to keep still. And what we can then do is modify or advise on modification of MRI imaging sequences so that it can reduce the extent of the artifact. So this one here of the knee was a very good example of how you can modify an MRI sequence to reduce the artifacts. Probably one of the things that I've enjoyed most about, or one of the things that stick with me, is that there is a potential risk of patients going under general anesthesia having adverse reactions. And the hospital that I worked in previously didn't have enough money to buy a patient entertainment system. So we managed to design and build our own pediatric entertainment system for less than $200 US. using an old computer and a monitor that could be safely held into the room, be kept into the MRI scanner room, and the patients could then, or certain patients could then watch their movies or their favorite cartoons while they were undergoing their MRI scan, rather than having a general anesthetic. So this essentially reduced. It was a much safer option. The anesthetic team were not necessarily involved. It was certainly cheaper than an anesthetic team being involved, and it was also faster. So a typical anesthetic session may take a patient for 1 hour, whereas this would be reduced to a typical scan session of maybe 20 minutes. So that was something that was looked on very, very favorably. So having the know-how and the support of a medical physics workshop and electronic staff, as well as the pediatric medicine and radiology staff, was very, very good. So that's something that sticks with me, and I'm very, very proud of our inputs into achieving something that had a good positive outcome for patients. Other things that we may be involved with. So I have done a little bit of software development. So we may develop some applications where we want to ensure that staff who have undertaken safety training do understand what they have learned, and we give them a test. So design a little bit of software for them to answer questions, and we can keep records of ensuring that they've passed their, they've understood it and they've passed their tests. So that's one of the things that we may involve with, is occasionally do software development. Another one is clinical research. We were looking, in this case, looking at the growth plate here. We can see a sagittal image here of the knee, and overlaying onto an MRI image. And what we were trying to do was work out the thickness of the growth plate and whether we could identify any layers of this, within the growth plate of these young adolescent athletes. So it involves a little bit of physics in terms of calculating the the thickness and the layering of the growth plate. And so the physics would then be involved in measurement of numerical values, obtaining them from images, and then trying to calculate some parameters that would help measure the thickness of the growth plate in these healthy pediatric patients. The other thing as well is we were developing a technique to do calf muscle spectroscopy. So we weren't looking at protons, we were looking at another metabolite called phosphorus. And you can see here the red squiggles in the bottom here. So they're certain metabolites that can be detected using spectroscopy. So this is me lying on an MRI scanner bed with a basic MR safe materials. It's just a little pulley, and I exercise my leg, and I can measure these chemicals called phosphocreatine and ATP. And I can look at the changes of them. So consequently, we were able to develop a much more sophisticated and clinically useful tool that could fit inside an MRI scanner to measure this for a patient study. So it involved the medical physics software engineer, computer-aided design, and 3D printing of a calf exercise machine in order to measure metabolic changes associated with activity. And what we see here is, you can see here, these are multiple spectra showing the size of this phosphocreatine peak. So here we doing the exercise, and then we deplete this phosphocreatine, and over time it recovers back. And what we were looking to do was actually measure this for a group of patients who were undertaking cardiac drug trials. And we wanted to see how quickly they can recover from exercise while they were taking this drug. So a very interesting piece of research carried out here. The other thing we want to look at is interactions between the radio waves and the tissue. So when electromagnetic waves are interacting with the body, their wavelengths change. And this depends on the properties of the tissue. And at different magnetic field strengths, we use different frequencies, 128 megahertz, for example, or 64 megahertz at 1.5 Tesla, and the wavelengths change. And what we'll tend to find is we have some concerns about heating of implants of particular lengths. And we're involved in doing some measurements and calculations to ensure that patients with certain types of implants or certain shapes of implants are not at risk of having an injury as a result of the size of the implant that they have. I've mentioned this already, but the knee implants. So a little bit more on the physics about how what sort of physics might we want to use on a day-to-day basis, and how that would interact with any measurements that we want to make. So I just put a chart on here showing magnetic susceptibility of tissues. There's the diamagnetic, paramagnetic, and ferromagnetic. So back in the 1930s, it was found that oxygen, or oxyhemoglobin, and deoxyhemoglobin have different magnetic properties. And it was then I'd be able to identify and use this, that you can measure changes in blood oxygenation and MRI scans, and use it to provide some useful information. So back in the early 90s, it was now possible to measure changes in blood oxygenation associated with activity of patients lying inside an MRI scanner. So this would typically involve an imaging type of sequence and asking a patient to open and close their fingers or their fist for a period of 30 seconds and then rest, and then repeat this 30 seconds rest and 30 seconds active. And the pixels that you would see here would have an on-off increase or decrease in intensity based on the oxygen changes in blood oxygen levels. So why is this useful? Well, when it comes to actually looking at patients who have brain tumors, and brain tumors that are close to the motor cortex, a neurosurgeon might want to know something along the lines of, is this part of the brain still functioning properly? So this is motor tasks is one of the things that we can ask them to carry out. They can do language tasks as well. And what we are looking at for these blobs, these very bright signals here that would identify active brain regions. So the neurosurgeon would want to know that that part of the brain is still active and functioning correctly. So there is real application of these types of physical property changes associated and can be measured. So this here is part of the motor cortex, these small blobs are showing brain activity in the motor cortex of this of the patient. Here's one that's a little bit more obvious there on without the color. You can just see here a low-grade glioma tumor here, and you're seeing there still hyper-intense bright signals that were associated with brain activity during the task. So the neurosurgeon would then know that overlaying these images, the colored blobs, that these brain regions were not were functioning correctly. And not to debulk them during the surgical procedure. One of the new services that have started on our health board is MR guided laser ablation here. So you can see this photograph of a thermometer, basically, essentially, entered into the skull prior to the MR ablation. And what we're seeing here is these can be used to create hotspots in the brain to damage tissue, so that they can reduce the recurrence of epilepsy in patients that have been resistant to epileptic drugs. So this was a service that started in the last 2 years. So what you can see here is these color maps generating show the temperature maps of the regions that were heated up. And there you can just see the post-procedure and the T1 weighted contrast associated with it. So this is a new technique. It's much safer than the typical invasive surgical procedures. And one of the patients who underwent the surgery, who had tried all the drugs and had no success, was now seizure-free, and that was his. That was a very successful and positive Christmas present for him. So since the service has been introduced, we've done, I think, 7 or 8 patients now. So it's certainly shown positive results for all patients so far. Yeah. I talk about the clinical aspects of what we do, but we've also got to be aware of the guidance, the legal position that we're in, and we introduce new services and new procedures according to the legislation that we're required to abide by. And anything that we are involved that we often carry out risk assessments and provide standard operating procedures for staff that we work with and provide extensive training for them. And as well as that is the typical procurement of MRI scanners. We would often be involved in the discussions on the types of scanners, the magnetic field strengths, the design of the department, whether we need here, the top left is iron shielding. The magnetic fields around MRI scanners can be hazardous, so they may need to be shielded from the surrounding rooms. You can see here where there's a hole in the wall where they've inserted an MRI scanner. So it's ensuring that the correct design and the location of these MRI scanners within the hospital is appropriate. And then we would be involved in carrying out testing of the scanners, the acceptance testing of these scanners once they're delivered, and ensuring that they are appropriate and ready for use for patient scanning. Also, very simple things for the MRI and radiology staff and anaesthetic staff is certain pieces of equipment can't go too close to the scanner or they will malfunction. So asking for two-tone floor colouring to be laid can actually help anaesthetists and the MRI staff to locate anaesthetic machines, for example, and not move them too close to the scanner. Otherwise, they can stop working. And again, when an MRI scanner is delivered, we'd be involved in carrying out some typical physics tests to ensure that it's suitable to undergo patient scanning. But also be involved in providing fire and incident plans to the fire service, for example, and any safety staff that are involved in maintaining the facilities. So access to an MRI scanner room and area should be restricted because of the magnetic fields. And we'd also make aware that the firefighting equipment is made from materials that are non-magnetic, and people can't inadvertently walk in without having carried out some sort of screening, for example, pacemakers or electrical implants. One of the critical things is understanding that objects that are very, very small and may have some magnetic material in them can increase in weight and be accelerated to the scanner by up to 120 miles an hour or 200 kilometers per hour. And in some cases, the weight of the object can increase from its normal mass up to 250 times its own gravitational weight. So small objects like wrenches, depending on the amount of iron that they contain, can become very, very fast-moving projectiles that would cause serious injury. And depending on the iron or nickel content, you would be certainly cause a great deal of damage to a patient or a piece of equipment if that was allowed to enter into the MRI scanner room. And here you can just see me. What I tended to do here is try and provide videos for staff. Inside this tennis ball, there is a small token that shows you the effect of object when it sticks to a magnet. So it's just trying to really illustrate to staff when they come for MRI training. We'll always try and give them practical training when we're teaching new staff and making sure that they understand the risks involved. Other thing as well is I might do on 2 or 3 times a week is provide an implant safety assessment. So, for example, if a patient has a neurostimulator, it may be safe for the patient to undergo scanning. However, there may be restrictions on the amount of RF power that can be used by the scanner. So we would then examine the manufacturer's information, ensure that the guidance is followed, and provide appropriate information for the MR technicians and the MR radiographers. So, but often or occasionally we have implants that are undeclared. So an MRI patient may show up and they will tell the radiographer they have an implant and the scan would then be postponed. And if we don't have any information on the implant, then we really want to ensure that we are not going to scan the patient and give them a bigger problem than they already have. So writing implant safety advice letters for the radiographic staff and radiology staff is something that we do routinely on implants. And checking of equipment, anesthetic equipment, and also other pieces of equipment. If it's moved too close to an MRI scanner, it could malfunction. And it's ensuring that we know what the conditions of use are, and that is appropriately understood by the radiographic staff using the equipment. The teaching aspect of it as well is ensuring that we provide a comprehensive training guidance for trainee radiologists, radiographers, and other clinical scientists. So it's understanding from the basic physics principles to a pulse sequence diagram, to all the components of the RFs, the gradients, and the frequency phase encoding gradients, and how an image is generated, and the information that's used to generate an image, and the impact that it has on the image quality as well. Other things, we'll talk about gradients. We have here, why do you need gradients in an MRI scanner? Well, that's allowing us to locate where the protons are within the slice, and within the slice, and the location within the slice. However, when gradients operate, there is a potential risk that patients can experience a condition of peripheral nerve stimulation. So that's muscle twitching induced inside the body, and it's an unwanted byproduct of switching. So it's allowing us to identify where these signals are coming from, but these changing currents tend to generate large loops inside the body. And these loops of the gradients tend not to cause heating, but they may cause heating if you have metal implants in the region. So depending on which gradients are being switched on, the loops that are formed in the body have a potential to cause injury. The noise associated with MRI scanners can be very, very loud, so 100 decibels. So anyone remaining inside the scanner room, patients and carers, or anesthetic staff or radiology staff, are required to wear hearing protection by law because of the sound amplitude being sufficiently high to cause damage. So one thing I would typically do maybe every 4 or 5 years is come along and test all of the scanners for the noisiest MRI sequence that we can find, and then try it on the quiet sequences and look at any differences or changes in performance. So this is ensuring that staff exposure, as well as the headphones that are providing sufficiently good quality to the wearer or the staff member using them. And we all same thing we have an MRI scanner right next to an intraoperative theatre. So this is a great facility and it's great for patients. However, the noise from an MRI scanner inside a theatre can be very, very large. So we've had to introduce some soundproofing between the theatre and the scanner, because the theatre used independently of MRI scanning. And the neurosurgeons were initially very concerned about the noise levels. So we put measures into place to reduce the sound levels. So it's almost virtually inaudible to hear an MRI scanner making its loudest sound when you're in the intraoperative theatre. And it's only a matter of 10 meters from the center of the theatre to the MRI scanner. One of the new technologies that's coming along, which is quite surprising actually, a very, very low magnetic field strength, 64 millitesla. And it's portable, it can be used on wheels. And we have had our neurosurgeons and our interventional radiologists asking about this. So this has been approved in the US, but it's now awaiting for approval in the UK for use. So I do know it is being used in clinical research in the UK. However, we're just awaiting some clearance on use within the UK for patients. So would certainly be much more appropriate for patients that were requiring scans out of hours, and it would certainly answer some clinical questions. So even at such a low field strength, it can provide adequate image quality for diagnosis in certain conditions. So it has potential to improve patient impact. Yep. Okay, so I'll move on. One of the other things as well as one of the other vendors here, we have a much smaller magnetic field strength that's being offered by one of the other vendors. It's an 80 centimeter bore. So the bores of MRI scanners, because patients are getting bigger, is increasing. So it typically was 60 centimeters, and now it's up to 80 centimeters. So there are some issues with this, but this one has only less than a liter of helium, so it requires no quench pipe. So it's a progress in terms of the technology. So yeah, I will. So I'll finish up here, and what I'll say is, in the role that MR physics provides, or any medical physicist, the key aspect is that you can understand the science and apply it, and have a good understanding of what's required clinically, and any decisions that you make as a clinical scientist or you offer and advise is using the scientific principles, and also being able to communicate that science to patients and non-scientists and staff and clinical colleagues in a way that's very understandable. So the thing that I always follow is, if I can say something without using equations or lots of words, and that often involves visual pictures, it can often be very, very useful to produce patients thinking pictures, scientists thinking using equations, but most people find it much easier to use things that are visual, and providing good training for them so they can ask specific questions. So yeah, so I think on that point, I would like to say thank you very much, and hand back over to Sylvia.
Thank you very much. So maybe we have time for 2 questions. Yes, organizers. Okay, somebody has a question? No? No? I have a question. In this case, you
Vamos a finalizar nuestra semana de festejo de los 50 años del Departamento de Física con uno de los grandes maestros que ha tenido nuestro departamento y que además tiene mucha historia, que nos ha inspirado a muchas generaciones para hacer nuestro trabajo de investigación, docencia y divulgación. Presentamos ahora al doctor Eduardo Piña Garza, quien nos va a contar gran parte de su historia. Doctor, adelante.
Buen día. Me pidieron que participara en estos festejos del Departamento de Física en que se celebran los 50 años de trabajo continuo de la Universidad Autónoma Metropolitana. Entonces, mi participación se reduce a ciertas memorias, ciertos recuerdos y ciertos comentarios relativos a la situación actual en nuestro país y en el mundo. A 50 años de distancia, es claro que han cambiado mucho la situación del país y del mundo en el que vivimos. La ciencia se ha continuado desarrollando con una rapidez extraordinaria, obligando a las personas a tratar de alcanzar la producción del conocimiento, lo cual se ha vuelto casi imposible por la rapidez con que se está produciendo conocimiento en el mundo. En particular, la física se ha desarrollado muchísimo en muchas direcciones. Su conexión con la física médica y con la biología ha crecido enormemente y se está haciendo desde hace más de 10 años una inversión enorme en las aplicaciones de la ciencia para la vida. Pero hay muchas otras actividades en física, tan diversas, tan extendidas, que no se pueden resumir en unas pocas palabras. El país, al mismo tiempo, se ha desarrollado mucho. Se ha ido democratizando poco a poco en los últimos 50 años. El inicio de la UAM es posterior a los movimientos del 68, en donde coincidieron, por una parte, la celebración de la Olimpiada y los festejos relativos, y al mismo tiempo un movimiento político en donde se buscaba la democratización del sistema mexicano, lo cual se logró de manera bastante lenta, pero segura en los últimos años. Recientemente hay nuevos cambios. Es muy difícil evaluarlos, aunque ya llevamos 6 años de un nuevo tipo de gobierno. 6 años es poco tiempo comparado con los 50 años de que hoy estamos hablando. Y se necesitarán quizá otros 50 años para saber el significado real de qué fue lo que representó esta transformación que estamos viviendo y que nadie sabe hasta dónde va a llegar, en qué va a consistir, cuáles son sus elementos. De todos modos, es muy importante darse cuenta que la historia la hacemos nosotros, que la historia la hacen los jóvenes preparados que piensan en los problemas y buscan soluciones a los problemas. Estos jóvenes probablemente van a plantear nuevos caminos de desarrollo para nuestra patria, para nuestra universidad, para nuestra ciencia. Que habrá que seguir esos caminos nuevos porque implican un progreso con ideas nuevas que no las tenemos todavía, porque las ideas nuevas dejan de ser nuevas cuando ya se conocen. Muchos de nosotros estamos tratando de hacer investigación. Investigación es la creación de nuevos conocimientos. Nuevos conocimientos no solo teóricos, sino también experimentales, producto del análisis de la naturaleza que nosotros hemos ido transformando y que cada vez más controlamos. Los problemas del control son ahora de actualidad. Los problemas de la inteligencia artificial que se está penetrando hacia nosotros. Algunos todavía no entendemos lo que significa esta nueva revolución que estamos viviendo hoy de una inteligencia artificial en la que no creían los que hacían la computación, en la que no creían los físicos, en la que no creían los biólogos. Sin embargo, los avances apoyados en hacer un nuevo tipo de computación, basada mucho en la estadística y con ideas totalmente nuevas, utilizando el poder enorme de las memorias que se manejan en estos tiempos y que hace 20, 30 años no existían. No había memoria suficiente para poder procesar las imágenes de manera adecuada. Hoy, en cambio, disponemos de memoria suficiente para hacer procesos fabulosos y además se ha acelerado la posibilidad de manejar la información. No solo tenemos disponible una gran cantidad de información, sino tenemos disponible una gran velocidad de análisis de esta investigación que hace totalmente nueva la vida que estamos viviendo. Hay cambios tremendos. Hace 3 años, hace 4 años, se afirmaba este sistema de criptografía no lo puede romper nadie, se necesitarían la vida del universo para romperlo. Y en la semana actual, al contrario, todos los sistemas criptográficos están en peligro de ser decodificados por la potencia tremenda de las computadoras. Entonces se están preocupando todos los que quieren guardar secretos. Nosotros no, nosotros somos científicos que lo que queremos es lo contrario, develar los secretos de la naturaleza. Y entonces esta inteligencia artificial nos da una potencia enorme, nos da la posibilidad de tomar en cuenta mucho de lo conocido, a pesar de que ha crecido tanto. Las herramientas actuales nos dan la potencialidad de analizar una cantidad de información enorme que sería imposible analizarla por una persona. Pero una persona dirigiendo los sistemas de computación actuales puede hacer un filtrado de la información que quiere realmente analizar y buscar su progreso y obtener resultados totalmente nuevos en campos de la ciencia, la física, la química, la biología y todas sus combinaciones que ahora se están dando en la realidad. Entonces, pues sí, estamos festejando 50 años de la UAM. Pero a 50 años de la UAM estamos llegando a una situación totalmente diferente de la realidad. Tenemos además el problema de muchos profesores de edad avanzada ¿verdad? Que tienen el problema de que ya se van a retirar. Eso es un problema porque no hay un sistema económico que les permita vivir como estaban acostumbrados a vivir en estos últimos 50 años. Ese problema no es un problema de México, sino de todo el mundo. No se ha resuelto. No hay todavía solución. Todavía no se ha creado los sistemas necesarios para resolver las dificultades que tienen que ver con ello. Son dificultades relacionadas con el análisis de la realidad, ¿verdad? Y tratar de plasmar las demandas de nuestra Constitución con respecto al género, con respecto a la edad, con respecto a la niñez. Esos problemas que subsisten y que se están tratando de resolver, y hay mucho trabajo en favor de ellos. Los que son todavía suficientemente jóvenes deben de estar optimistas ante el futuro que se presenta. Recordando al doctor García Colín, uno de los fundadores el fundador de nuestro departamento y uno de los que empezaron a fundarlo, junto con algunos de ustedes, él decía que la mayor parte de los problemas de un científico se resolvían si él producía una suficiente investigación, si obtenía resultados importantes en su trabajo. Y nos dio el ejemplo. Continuamente, desde en los 50 o casi 50 años que él vivió en la UAM, siempre estuvo produciendo y enseñando a sus alumnos a producir la ciencia que les daba la seguridad de vivir bien, resolviendo muchos de los problemas que otros mexicanos no han podido resolver. Estuvieron con él muchas gentes, pero se están yendo algunos. Unos más rápido, otros menos rápido. Recordamos a Roberto Alexander, por ejemplo, que es una de las personas que nos abandonó. Uno de los primeros que llegó con él el 1 de junio de 74 fue Jesús Robles Domínguez. Fue el tercer miembro del departamento en la UAM y ya se fue. Tere de la Selva estuvo el miércoles aquí en este festejo. También ya se va. Rosita Velasco, que fue una de las alumnas más destacadas, que aprovechó mejor los conocimientos de Leopoldo García Colín, ya se va. Entonces, los que se quedan, hay que reemplazar toda esa actividad, esas ideas, esos estandartes de trabajo que van llevando a resolver los problemas del país en lo que nos compete, que es la física. Y al mismo tiempo, tenemos que dar lo máximo para seguir preparando gentes jóvenes que sigan, que tomen la estafeta y sigan el camino de... La gente de edad pues ya no viene, iban a venir otros y ya no llegaron. Y yo también pude haberme quedado en el camino, ¿no? Ya las circunstancias no me garantizan para nada el que yo pueda estar con toda seguridad en un lugar, en un momento. Seguir trabajando, sí, seguimos trabajando. Este martes colgamos el póster en este evento, un póster que realicé con la ayuda de la profesora Marta Álvarez Ramírez del Departamento de Matemáticas, quien es una experta en el tratamiento de los sistemas, lo que se llama mecánica celeste, que es una rama ahora de las matemáticas, y ella colaboró conmigo en esto, y ese trabajo lo presentamos al mismo tiempo, el mismo trabajo en Chihuahua, en el Congreso de la Sociedad Mexicana de Física. Se presentó el miércoles en Chihuahua, el mismo trabajo. Entonces, y ese trabajo, esta semana, nos lo aprobaron para publicación en la Revista Mexicana de Física. Son ejemplos de que seguimos trabajando, algunos de nosotros. Seguimos haciendo cosas. En Chihuahua presenté otro trabajo, un trabajo que se refiere a una publicación que apareció en 1839 y que encontré, no estoy equivocado, 1829, eso es cuando ya acaba la presidencia del presidente Guadalupe Victoria, de apellido Fernández, pero se cambió su nombre a Guadalupe Victoria. Nosotros estuvimos tomando tours en Chihuahua, en la calle de Guadalupe Victoria. Y ese trabajo de historia que presento, sacando un libro viejo de la biblioteca de los ancestros de la familia, es una historia natural de Plinio, pero tiene un comentario escrito por un historiador astrónomo de la primera tercio del siglo XIX. Y nos presenta una astronomía en donde presume ya datos que él dice que son exactos, y son los datos que casi coinciden con datos astronómicos de los planetas en la etapa actual. Pero al mismo tiempo, ya tiene conocimiento de lo que hicieron los griegos y presenta ahí algunos dibujos para explicar cómo explicaban los griegos algunos de los argumentos que Plinio trata en su historia natural de una manera superficial. En ese trabajo se me ocurrió una idea, leyendo esos trabajos. Esta idea que se me ocurrió las quiero compartir con ustedes, es como que la compartí en el Congreso. Es algo de historia, de la astronomía, y sin embargo es una idea que creo que no se ha dicho. Los griegos tuvieron un sistema muy complicado que resumió Ptolomeo en un trabajo que se llamó el Almagesto. Se publicó por ahí del segundo siglo después de la era cristiana. En ese trabajo habla del movimiento de los planetas como dos movimientos circulares. Un movimiento con velocidad angular constante era el eferente, y otro movimiento centrado en la periferia del anterior, moviéndose con el anterior, ese centro del otro círculo, el segundo círculo también moviéndose con velocidad angular constante. Cuando yo supe esto hace algunos años, me pareció demasiado artificial. Y en el Congreso me doy cuenta de que no es otra cosa que el sistema de Copérnico. El sistema de Copérnico, sí aceptamos con Copérnico que todos los planetas se mueven en círculos alrededor del Sol con velocidad angular constante, como lo suponía Copérnico, haciendo un avance respecto a esta astronomía de los griegos. Pero los griegos veían las cosas desde la Tierra. Entonces, tenían desde la Tierra lo que se ve es que el Sol da una vuelta con velocidad casi constante alrededor de la Tierra, dando una vuelta alrededor de la Tierra en un año. Y al mismo tiempo, los planetas se mueven alrededor del Sol. Entonces, el movimiento de los planetas desde la Tierra se puede ver como la suma vectorial del movimiento del Sol más el movimiento de los planetas. Y si cambian el orden de los vectores de la suma vectorial, debido a que esta suma es conmutativa, dicen los matemáticos, entonces lo que se tiene es el movimiento de los griegos, de dos círculos que se mueven con velocidad angular constante. Esto viene a ser corregido con los avances de las leyes de Kepler, pero esos avances son cualitativos, cambian un poco la forma de, en vez de círculo es elipse, en vez de velocidad angular constante, la velocidad cambia, ¿verdad? Pero mantiene la velocidad areolar constante. Darse cuenta de que avanza mucho la ciencia, pero hay cosas que creemos que son anticuadas y que resultan, se pueden encontrar versiones modernas en donde hay coincidencias, en donde hay equivalencias. Eso en la ciencia lo hacemos todos los días al ir uniendo conocimientos de campos diferentes y así va avanzando la ciencia. Y esto debe de ser también en la política, donde se deben unir las experiencias, encontrar soluciones comunes que vayan actualizando las ideas antiguas de libertad, de justicia, de democracia, buscando nuevas formas de convivencia entre todos nosotros. Pues es lo que yo quería decirles y les agradezco que me hayan escuchado.
Le agradecemos al doctor. ¿Alguien quiere preguntarle algo? Ya tienen hambre. ¿Nadie? Doctor, pues le agradecemos mucho. Vamos a comer.
Con esto damos por terminado toda la...
Bueno.
Es una de las primeras veces que recibo flores. No veo por qué todas las mujeres deban recibir flores. Yo también, a mí también me gustan las flores y las mujeres.
Bueno, muchas gracias. Bueno, muchas gracias a todos y a todas por estar aquí con nosotros, acompañándonos en esta celebración del 50 aniversario del Departamento de Física. Con esto damos concluido nuestras sesiones de trabajo y los invitamos a degustar un vino que está esperándonos allá afuera y una taquiza. Entonces, adelante por favor y con esto concluimos nuestro programa. Muchas gracias.
Gracias.